Patients here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in emergency
in your left hand.
for 45 minutes of CPR.
We can stop CPR with 600.
Imagine handing your patient just a standard routine morning pill for their depression.
Right, something that happens, thousands of times a day.
Exactly.
Yeah.
But then a few hours later, you're suddenly calling a rapid response because they're having a massive, life-threatening gastrointestinal bleed.
Oh, wow.
And the kicker is, you didn't give them a blood thinner, you gave them an antidepressant.
Yeah, and that is just the harsh reality of pharmacology. I mean, we like to think of medications as these targeted missiles, right? But honestly, they're often more like dropping a boulder into a pond. The ripples end up hitting systems we never intended to disturb.
That is such a good way to put it. So welcome to this deep dive, and we are talking directly to you today.
Yes, the dedicated learner.
Exactly. Whether you're a nursing student gearing up for clinical practice or, professional staring down the barrel of those notoriously tricky NCLEX-style exams.
We know your time is precious.
Extremely. So our mission today is to act as your elite clinical team. We're applying the Pareto principle to our source material.
Which means we're going to extract the high yield 20% of the information that is going to give you 80% of your practical bedside understanding.
Right. And today we're doing a comprehensive clinical profile of the medication venlafaxine.
Yeah, and we're going to deconstruct this step by step because, before you can safely administer any drug, you really have to understand its identity.
Like, what is it actually doing at a cellular level? Right, let's establish that baseline first.
Okay, so venlafaxine, which you'll often see under the brand names Effexor or Venbc XR, is classified as an oral serotonin norepinephrine reuptake inhibitor, or SNRI.
Okay.
It's primarily used as an antidepressant.
Yeah.
And the mechanism of action is, it's right there in the class name, right? It inhibits the central reuptake of serotonin and norepinephrine.
And there's some weak dopamine inhibition too, right?
Yeah, a little bit of dopamine inhibition, but mainly serotonin and norepinephrine.
Okay, let me stop you there for a second because the sources highlight this really fascinating statistical quirk about how it balances those chemicals.
Oh, the affinity ratio.
Yes. The data states venlafaxine has a 30-fold higher affinity for serotonin compared to norepinephrine.
Right, 30 to 1.
30 to 1.
Yeah.
So if it favors serotonin that heavily, aren't we basically just giving the patient a standard SSRI at lower doses?
That's a brilliant way to conceptualize it. And you've really hit on a vital concept for clinical practice here.
Oh, really?
Yeah, because of that massive 30 to 1 affinity ratio, at lower doses, say around 75 milligrams, the clinical profile of venlafaxine looks almost identical to a selective serotonin reuptake inhibitor.
So it's basically an SSRI in disguise.
Exactly. At that dose, it's primarily modulating mood and anxiety entirely through the serotonin pathway.
So the norepinephrine doesn't even, show up to the party until we push the dose higher.
Precisely. As the dosage increases, that's when that norepinephrine reuptake inhibition finally becomes clinically significant. And this dual mechanism at higher doses makes its clinical profile incredibly diverse, but it also dictates the escalating side effect profile you have to watch out for.
Right, which brings up the timeline. The text notes this medication has a delayed therapeutic response.
Yes, very important to remember.
But wait, if the drug is blocking the reuptake of these chemicals in the brain within hours of the patient swallowing the pill, why does it take weeks for their mood to actually improve?
Well, because the immediate flood of neurotransmitters in the synaptic cleft isn't actually what cures the depression.
Wait, it's not?
No, the brain has to adapt to that new chemical environment. It requires long-term neurotransmitter receptor modulation.
Okay.
The physical architecture of the receptors actually downgrades and remodels over several weeks.
Wow. So we are literally forcing the brain to slowly rebuild itself.
Exactly.
And I guess that multi-pathway remodeling explains why the indications for this drug extend far beyond a typical psychiatric ward.
Oh, absolutely. I mean, the primary FDA-approved uses are major depressive disorder, generalized anxiety disorder, social anxiety disorder, and panic disorder.
Right.
But the off-label uses are just as clinically relevant.
Yeah, the off-label uses really caught my eye, like fibromyalgia and painful diabetic neuropathy.
Yeah.
I mean, how does an antidepressant fix nerve pain in a diabetic foot? That doesn't seem to make sense.
It comes down to the descending pain pathways in the spinal cord.
Okay.
Your central nervous system has this built-in pain suppression system, and it relies heavily on both serotonin and norepinephrine.
Oh, so because it boosts those two.
Exactly. When you boost those two neurotransmitters, especially those higher doses where the norepinephrine kicks in, you basically amplify the spinal cord's ability to mute incoming pain signals.
It's like a neurological Swiss Army knife.
I like that.
Yeah. The serotonin blade handles the mood, and the norepinephrine blade handles the nerve pain.
That's a great analogy.
There's another off-label use that feels like a massive priority for our nursing listeners, and that's treating hot flashes.
Yes, this is huge.
The text specifically highlights it as a first-line non-hormonal alternative for women going through menopause, or, importantly, women undergoing breast cancer treatment.
Yeah, this is a really critical clinical application. You have to understand the hypothalamus acts as the body's thermostat,
Right.
and it relies on a really delicate balance of estrogen and neurotransmitters. So when estrogen drops precipitously, like during natural menopause or, chemical menopause from chemotherapy.
The thermostat breaks.
Exactly. It suddenly thinks the body is boiling and triggers a massive, completely inappropriate sweat to cool down.
Okay, let's connect that to the breast cancer patient. If you have a patient taking, say, tamoxifen for an estrogen receptor-positive breast cancer, you obviously can't give them hormone replacement therapy for their hot flashes.
Right, because you would literally be feeding the cancer.
Exactly, which is why venlafaxine steps in as the hero here.
Yeah, by boosting serotonin and norepinephrine in the hypothalamus, it effectively recalibrates that broken thermostat. And it does it without introducing a single drop of estrogen.
Yeah, it's incredible.
It really is. In clinical trials, venlafaxine dropped vasomotor symptoms, the hot flashes, by over 47%.
Over 47%. So when a nurse sees venlafaxine on an oncology patient's chart, they really shouldn't automatically assume the patient has comorbid depression.
No, not at all. It might be entirely for symptom control.
Makes total sense. Okay, let's shift gears to the journey of the drug through the body pharmacokinetics. Because a drug's therapeutic potential doesn't matter if the body can't actually process it.
Right. So venlafaxine is well absorbed from the GI tract, but it undergoes extensive metabolism in the liver.
Okay.
It's heavily metabolized by the cytochrome P450 enzyme CYP2D6. And here's the really interesting part. The liver turns it into a major active metabolite called O-desmethylvenlafaxine, or ODV.
Wait, so the pill you swallow isn't actually doing all the heavy lifting on its own?
Nope. The liver transforms it into a second active compound.
Why does it matter that there are two active versions floating around in the body?
Because it changes the timeline. The parent drug, venlafaxine, has an elimination half-life of about 5 hours.
Okay.
But that active metabolite, OBV, has a half-life of 11 hours. So the liver isn't destroying the drug's effect, it's actually extending the therapeutic window.
Oh, wow. Okay, so knowing the liver is doing that intense metabolic conversion and the kidneys are eventually excreting it, what are the hold parameters when those organs are failing?
Right, so hepatic and renal impairment require major dose reductions.
Like how much?
For mild to moderate hepatic impairment, you are reducing the dose by 50%.
Wow, half.
Yeah, and for severe hepatic cirrhosis, it might need to be reduced even further. And the exact same rule applies to severe renal impairment or patients on intermittent hemodialysis. You must reduce the total daily dose by at least half.
Got it. Let's talk about traffic jams in the liver.
Traffic jams.
Yeah, you mentioned CYP2D6 as the main enzyme breaking this down. I like to picture that enzyme as like a single-lane bridge out of the liver.
Oh, I like that analogy. So venlafaxine is a major substrate driving on that CYP2D6 bridge, but it is also a weak inhibitor.
Okay, meaning?
Clinically, if you combine venlafaxine with a potent CYP2D6 inhibitor, so another drug that completely blocks that single lane, the venlafaxine backs up.
It can't cross the bridge.
Exactly. It accumulates in the bloodstream, leading to elevated, highly toxic plasma concentrations.
Okay, I want to zero in on a classic NCLEX trap in the source text regarding the extended release capsules, because it honestly sounds like a complete contradiction to me.
Let's hear it.
The text explicitly says Do not divide, cut, chew, crush, or place the capsules in water.
Right. Standard extended release rule.
But then, in the very next breath, it says you can open the capsule and sprinkle the contents on applesauce.
Yeah.
How is opening the capsule not considered breaking the rule?
Well, because the plastic shell of the capsule doesn't actually do anything. The extended release mechanism is entirely engineered into the microscopic pellets inside the capsule.
Wait, so the physical capsule itself is useless. It's literally just a carrying case for the pellets.
Yeah. Think of the capsule shell as Tupperware.
Tupperware.
Yeah, it just holds the active ingredients. If you open the Tupperware and carefully sprinkle those intact pellets onto a spoonful of applesauce, the extended release property is 100% preserved.
Okay.
The patient swallows the applesauce, the pellets hit the stomach intact, and they slowly release the drug over 24 hours.
Okay. But the trap is the chewing.
Yes. If the patient chews the applesauce and crushes those tiny pellets...
They destroy the extended release coating on a microscopic level.
Exactly.
Which means they get a massive 24-hour toxic dump of the medication into their bloodstream all at once,
causing a dangerous immediate release. And that is why the patient education must be so specific. You can sprinkle it, but you must swallow the drug-food mixture immediately without chewing a single pellet.
And then follow it with a glass of water, right?
Yes, to wash it all down safely.
Man, that distinction is going to save someone's license.
Really?
So if a massive dump of this drug hits the bloodstream, what is that actually doing to the patient? Because manipulating powerful neurotransmitters inherently creates friction in the body's systems.
Oh, absolutely.
And the side effect profile in our sources is staggering. I mean, nausea occurs in 21 to 58% of patients in early treatment.
Yeah, nausea is actually the single most common reason patients discontinue the medication prematurely.
Not surprising.
We also see significant dose-dependent weight loss up to 47% of patients, along with headache, drowsiness, and insomnia affecting around a quarter of people taking it.
Okay, let's get to the dark side. The serious, life-threatening adverse effects.
Okay.
At the start of this deep dive, we talked about a patient having a gastrointestinal bleed from an antidepressant. Break down the biology of that. How does an SNRI cause internal bleeding?
It's a really fascinating mechanism. So platelets in your blood are responsible for clotting, right?
Right.
But platelets don't manufacture their own serotonin.
Wait, they don't?
No, they actually have to vacuum it up from the bloodstream and store it.
Right.
Then, when they need to form a clot, they release that stored serotonin to aggregate together.
Oh. And because venlafaxine is a serotonin reuptake inhibitor, it blocks that vacuum.
Exactly. The platelets are blocked from taking in serotonin, so they're empty.
Wow.
So when a microtear happens in the stomach lining, the platelets arrive at the scene, but they lack the serotonin needed to actually form a strong clot.
The result being a significantly increased risk of severe gastrointestinal bleeding.
Exactly.
That is wild. But we also have to watch the heart, right? The text mentions severe arrhythmias, specifically ventricular fibrillation and torsade de pointe.
Yeah, very serious.
Let's unpack torsade de pointe. Why would a mood drug throw the heart rhythm into chaos?
It has to do with the heart's electrical reset time, which is known as the QT interval. Certain medications, including venlafaxine, can stretch that reset time out. And if the QT interval is prolonged too much, the electrical system gets confused, and the ventricles start fluttering out of control in this, chaotic rhythm.
And that is torsade de pointe.
Yes.
But if the drug is causing this electrical chaos
Right.
and ramping up the sympathetic nervous system, why wouldn't we just give the patient a beta blocker to shield the heart?
Well, because a beta blocker might lower the physical heart rate, but it doesn't fix the underlying electrical QT prolongation.
Oh, right.
Plus, you are venturing into dangerous polypharmacy there. You can't just mask the cardiac effects of a psychiatric drug with another drug. You have to monitor for them and adjust the offending agent.
Especially considering the norepinephrine effects. The text states SNRIs act like the fight-or-flight system stuck in overdrive.
Right, because norepinephrine is the primary neurotransmitter of the sympathetic nervous system.
So basically hitting the gas pedal.
Exactly. The data is clear. Venlafaxine can increase blood pressure and heart rate so severely that it literally requires immediate medical treatment.
So I noticed another strange contradiction in the side effects.
What's that?
Well, we just said it puts fight or flight into overdrive, which usually means sweating and activation, right? But the sources highlight anticholinergic side effects, dry mouth, urinary retention. And the text even notes it lacks muscarinic affinity in laboratory tests.
Yeah.
So why are patients drying out?
It's a physiological paradox. Even though venlafaxine doesn't directly bind to muscarinic receptors in a test tube, which is, the classic pathway for anticholinergic effects,
Right.
its complex modulation of norepinephrine in the peripheral nervous system still yields those clinical results.
Oh, interesting.
Yeah, so the patient gets the dry mouth, the constipation, and the urinary retention anyway.
Man, the body is complicated. Okay, we need to talk about the most severe warning in the text. The FDA black box warning for suicidality.
Yes, absolutely crucial. Venlafaxine carries a boxed warning for an increased risk of suicidal thoughts and behaviors in children, adolescents, and young adults up to 24 years of age.
And it's particularly during the initial stages of treatment, right? Or during dose adjustments.
Exactly.
But why would an antidepressant make a young adult suicidal? That seems completely counterintuitive to the entire purpose of the medication.
I know it does. But think about the timeline of the mechanism we discussed earlier.
The receptor remodeling.
Right. In week 1, the drug starts blocking reuptake. The patient gets a physical energy boost from the norepinephrine,
Okay.
but the serotonin receptor remodeling hasn't happened yet. Their mood hasn't actually improved.
Oh, I see. They're still deeply chemically depressed, but now they suddenly have the physical energy and motivation to actually carry out a suicidal plan.
Exactly. That is known as the activation syndrome. The energy returns before the mood lifts.
That's terrifying.
It is a highly dangerous window. Furthermore, venlafaxine causes dose-dependent weight loss and significant growth inhibition in pediatric patients. So that requires careful long-term tracking, too.
Okay, let's turn all of this into actionable nursing interventions. If I am the nurse, my assessments are heavily focused on monitoring.
Yes, nonstop monitoring.
I am checking blood pressure and heart rate constantly because of that norepinephrine overdrive. I am plotting height and weight on pediatric growth charts, and I am hypervigilant for behavioral changes in young adults.
All of the above.
But what do we tell the patient before they go home?
First, you have to address the massive nausea risk. Instruct them to take the medication with food. It dramatically minimizes gastrointestinal distress.
Okay, with food.
Second, compliance is vital. They must take it at the exact same time each day to maintain steady blood levels and avoid intense withdrawal symptoms.
Makes sense.
And third, educate caregivers of young patients to immediately report any agitation, hostility, or suicidal ideation.
All right. We have covered the cellular mechanics, the off-label surprises, the pharmacokinetic traps, and the biological reasons behind the black box warnings.
We covered a lot of ground.
We did. So to wrap up this clinical rotation, let's synthesize this entire deep dive into the ultimate rapid-fire clinical cheat sheet requested by our listeners.
I am ready. Let's do it.
Okay, Category 1, the must-know.
You must know the black box warning for increased suicidality in patients 24 years old and younger, driven by that dangerous energy before mood window.
Right.
And you must know the strict requirement to monitor blood pressure and heart rate because the norepinephrine reuptake inhibition acts as an overdrive for the sympathetic nervous system.
Great. Category 2, nice to know.
Venlafaxine is a highly effective first-line non-hormonal alternative for treating hot flashes.
That's a cool fact.
It is. This is especially critical knowledge for patients with estrogen receptor-positive breast cancer who cannot undergo traditional hormone replacement therapy.
Awesome. Category 3, the test trap.
The administration paradox. You can open the extended release capsule and sprinkle the contents on applesauce because the capsule is just a carrying case.
The Tupperware.
Right. But the patient must swallow it immediately without chewing a single pellet, or they destroy the extended release matrix and risk immediate toxic release.
So tricky.
And also the anticholinergic trap. Despite lab tests showing no muscarinic affinity, your real-world patients will still complain of dry mouth and urinary retention.
Good to know. Category 4, the clinical red flag.
Watch for unusual bleeding. By blocking serotonin uptake into platelets, venlafaxine robs the blood of its ability to clot properly, making GI bleeding a major risk.
Scary stuff.
And you must also be vigilant for severe cardiac events, specifically QT prolongation leading to arrhythmias like torsade de pointe.
Okay, and finally, our one-sentence memory hook. If you, the learner, remember nothing else, remember this.
Venlafaxine is the 30-to-1 serotonin-heavy SNRI that tackles depression and hot flashes, but you must watch their blood pressure, guard against suicidality in the young, and never let them chew the applesauce.
Never let them chew the applesauce. That vivid visual of the destroyed pellets dumping medication into the bloodstream is definitely going to stick with me.
I hope so.
As we wrap up this deep dive, I want to circle back to the very beginning, the delay in the therapeutic response. The source material states it requires long-term neurotransmitter receptor modulation.
Right. The drug alters the chemical soup in hours, but the clinical benefits take weeks to manifest.
That tells us something really profound about what we are actually doing to the patient.
How so?
Well, if it takes weeks, it means antidepressants aren't just filling a chemical pothole in real time. We aren't just topping off the serotonin tank like putting gas in a car.
Oh, I see what you mean. We are fundamentally altering the biological structure.
Exactly. It suggests we are forcing the physical architecture of the brain to adapt. We are making the neurons retract old receptors and grow new pathways in response to this new chemical environment.
Yeah, it isn't just pharmacology. It is neuroplasticity in action.
Right. I want you, the listener, to mull that over during your next shift. When you hand that little capsule to your patient, you aren't just treating a symptom. You are initiating a weeks-long physical remodeling project inside their brain.
That's a huge responsibility.
It is. It is messy, it requires immense vigilance, but it is undeniably fascinating.
A perfect way to look at it.
Thank you to our expert for deconstructing this complex clinical profile, and to you, the learner, good luck on your clinicals, good luck on your exams, and keep asking the deeper questions. We will see you next time.